Please join me in welcoming President of the Lown Institute, Vikas Saini.
Good morning. Test, yes. Good. Welcome, everyone. I'm Vikas Saini, and I'm president of the Lown Institute. So, as Judith said, we're delighted to have everyone here. I think it's going to be a great day, hopefully full of incredible conversation. I hope some arguments, but we'll see. Let me tell you a little bit about the Lown Institute for those who don't know. We're a Boston-based think tank founded by Bernard Lown, who was a Harvard cardiologist, social activist, and Nobel laureate. He invented the first working defibrillator, built some of the early coronary care units. So he was really comfortable with technology, but he understood how much it can be a double-edged sword. In fact, his motto was, do as much as possible for the patient and as little as possible to the patient. And in his clinic, he did everything he could to hold back the tide of expensive technology. And he taught his trainees, including me, that the heart of healing is really in the relationship. It's what patients want most is to be seen, to be heard, to be understood by a caring and competent clinician. So at the Lown Institute, we believe in that kind of care. We think that's the least costly care there is. And so that's our DNA, and that's why we're here today with you. So a few thank yous. First of all, to KFF for this lovely space. We're really delighted and grateful that we have this opportunity. And then next, the Lown Institute wouldn't be here on this program today if it weren't for Noam Levy of Kaiser Health News. Noam, where are you? So his excellent and passionate reporting was the trigger for our involvement. And it was he who conceived and inspired the project that we'll tell you a little bit more about later. I also want to thank Arnold Ventures for their generous support, not only for this conference itself, but also for the work that my colleague Kelsey Chalmers will be presenting later. And then, of course, most importantly, I want to thank the members of the working groups that helped put this together. There were two working groups, one for this conference itself, and another that wrote a comprehensive reference paper that we'll be releasing in a few weeks. I'm not going to list them all, but just so you understand, this was a real collective effort. And so on behalf of the Lown team, I want to ask all of them if they could stand up. Anybody who was on those calls for the last year, you'll see quite a few people. Great, thank you. I just wanted the rest of the audience to see you, acknowledge you, and know where to send the hate mail. So let's talk about why we're here and what the day is going to look like. Our first panel will begin with the ending. We'll toss out some solutions and give you some answers even before we start asking questions. That's because I think you'll all agree everyone in this room has some idea of the story, so why not just dive in? After that, we'll learn a little bit and a lot about what we know about medical debt with some incredibly knowledgeable researchers. And then we're going to take a look at the nitty-gritty with a couple of visionary hospital leaders and some key advocates. And then the rest of the day is going to explore a wide range of solutions with an amazing group of thinkers. So Judith also already mentioned the format. We really want this to be interactive, so feel free to start writing your questions and comments down now. So in the last few minutes, I just want to exercise my prerogative to sort of set the stage in the way I'm seeing it. First of all, my background is pretty eclectic. You can read about it online. I'm not sure it makes any sense except maybe as preparation for this moment today. But I studied politics, philosophy, and history as an undergrad. Then I became an internist and cardiologist, training at Hopkins and Harvard after med school in Nova Scotia. So I'm a damned Canadian. I practiced cardiology for 35 years, both in the ivory tower and in the lovely community setting of Cape Cod. And I've held positions with many different vantage points in the system. I did animal research in a lab at Harvard. I co-founded a medical device company, raised money in Silicon Valley, and started first for that company corporate research around the country in academic medical centers. I founded a primary care network that took global risk, upside and downside, successful group, and with that learned how to negotiate with health plans, hospitals, specialists, and you name it, as well as getting my colleagues to figure out how to operate on a fixed budget. And these days at the Lown Institute, where I am now, our task is to develop bold ideas for the kind of healthcare system that everyone in the United States says they want, which is one that is effective, affordable, and just. So we're going to be talking a little bit about the causes and solutions of medical debt. We'll be doing it all day. But I think we have to acknowledge that medical debt is a symptom. So you can take an aspirin, Tylenol for your fever, that doesn't make it go away. The symptom is of the deeper affordability crisis in the country. So any permanent solution, if we aspire to permanent solutions, have to look at the underlying drivers of high costs. And there's no mystery about what those are, and I think everybody in this room could probably name them. So let me just do that. In no particular order. Consolidation and monopolies, relentless technological innovation, some of which is near miraculous, but too much of which is capital intensive and a waste of time. Wasteful administrative costs from a ridiculously complex insurance system. Then there's Baumol's disease, the Princeton economist William Baumol, which is the tendency of service sector costs to rise relative to manufacturing costs. The increasing prevalence of chronic disease, which is getting its day in the sun with Bobby Kennedy, with mixed results in my view. An aging population, and maybe there's a fix for that. And then something the Lown Institute highlights every year with our annual Shkreli Awards, and something we shouldn't be afraid to say out loud: a growing culture of greed, grift, and rent-seeking. So obviously we're not going to get to all this today, but we should remember these things, because otherwise we're going to be condemned to a perpetual game of whack-a-mole. Every time we try, we'll fall short. So finally, let me just say that medical debt is not a Democrat issue. It's not a Republican issue. It's an American issue. When we're healthy, we, the living, forget our mortality. But when illness shatters that illusion, the kind of anxiety it triggers, whether you're aware of it or not, that anxiety is not the time to be worrying about money. So for the wealthiest society in history to impose financial fear on the sick, to me, is just grotesque. A nation whose people are forced to choose between medical treatment or food, housing, or heating cannot call itself a great nation. So let me just say that neoliberalism's answer to all this, co-pays and deductibles, is a failure. In over 35 years of practice, I've seen almost no one come in for care just for kicks. Charging $35 a visit to someone making $15,650, you can look that one up, that is not going to fix the system. So let's be serious. As my friend Rashika Fernandopoulos once said at a Lown conference many years ago, patients already have skin in the game, their actual skin. So if you look at the various crosstabs of the KFF surveys, which I did preparing for this talk, I actually was flabbergasted. Working on this issue for a year, looked at some of these numbers, I found them hard to believe. So I hope the methodologies are good. But here's one: 44% of insured working age adults had experience with some form of medical debt, current or otherwise. That means out of roughly 217 million working Americans under the age of 65, over the age of 18, something like 95 million are in that group, and that does not include seniors. And here's one thing that's easy to forget, because medical debt is usually reported as a rate in various populations. The rates are higher in people with lower incomes. They're higher in younger people. They're higher in blacks and Hispanics and in women. Not exactly a surprise. But make no mistake about where the largest numbers of people with medical debt are. With the KFF numbers, I calculated that anywhere between 90 and 130 million, I don't know, 90 to 130 million out of a total population of 255 million white folks in America have now or in recent years experienced some form of medical debt. That is to say, medical debt is a key problem in the lives of non-college educated white working class people, particularly women. Need I point out that Donald Trump won that constituency by 28 points? I think Senator Josh Hawley seems to know that, given what he's been saying lately. So we're all here because this issue really is a moral stain on the fabric of the country. We're here because too many of our friends and neighbors, our brothers and sisters, our parents, our children, too many of them are grappling with a difficult, sometimes intolerable situation. So if we're going to be declaring national emergencies, maybe this is one. But we're also here because if we want to fix this, we can. So thank you for listening. Let's turn to the first panel now.